Good afternoon and welcome. It's a great pleasure on behalf of the Department of Medicine to ask Dr. Paari Dominic to present today. Now, most of you recognize that he's an electrophysiologist, and he comes by that by way of the by Chicago University. His cardiovascular training in Iowa and continued training in EP at Yale. But he has a strong interest in all things cardiology and has really been a force with us in developing a number of programs. Most of you are also aware that he's co-director of LCATS and actively involved with the Cardiovascular Center for Research in areas relating to arrhythmia and other events. But all of these do directly relate to heart failure. Thank you so much for taking on this opportunity to bring a more organized heart failure approach to us, and we look forward to hearing more about an update in 2019. Thank you, Paari.
Thank you, Dr. Bailey. Guys, can you hear me at the back? Yep. All right, so I am a cardiac electrophysiologist, but as Dr. Bailey mentioned, I think the bread and butter of cardiology is heart failure, and most of the EP procedures and EP patients have heart failure, and therefore, without a heart failure program, EP or interventional for that matter, cannot actually have a successful practice in any cardiology section in the country. So with that, I'm going to give my talk on updates on the heart failure treatment, and I'm going to talk to you a little bit about which patients are at high risk of getting readmitted to the hospital, and I'm going to talk to you a little bit about guideline-based management of heart failure, and lastly, I'm going to touch up on some economics of heart failure therapy. So that's the content for today: workup of initial heart failure labs and prognosticators, pharmacotherapy for heart failure, and our own performance in heart failure therapy. And the last thing I'm going to say is economics of heart failure. All right. So as you guys know, there is a classification for heart failure, and there's these NYHA class for heart failure, and there is these stages of heart failure, which we say stage A, B, C, or D. And stage A basically means that you haven't developed heart failure yet. You're going to develop heart failure. You have risk factors for developing heart failure. And then from B to D, you've already developed heart failure. Either you don't have symptoms, as in class stage B, or then stage C or D, you're having symptoms of heart failure with the diagnosis of heart failure. And in stage D, you're having refractory heart failure requiring multiple specialized interventions. So NYHA class basically starts from stage B. So class 1, you're asymptomatic, and class 2, you're symptomatic with moderate exertion, class 3 with minimal exertion, and class 4 with at rest, you're still symptomatic. So what is the risk of mortality for patients with heart failure? Unfortunately, we do not recognize that heart failure has significantly high mortality like cancer patients, and therefore we fail to make our patients understand that heart failure has this serious mortality risk. If you are a class 1 heart failure patient with basically you're asymptomatic, you have an EF less than 40%, you don't have any symptoms, you still have a 5 to 10 year mortality risk for the first year. And if you are stage 3 heart failure, which is most of our heart failure patients that get admitted to a hospital, your risk of dying in the first year is about 25%. So it's a significant amount of mortality risk once you get diagnosed with one of these classes of heart failure. So for the rest of the talk, we're going to talk about HFpEF, HFrEF. So HFrEF is heart failure with reduced ejection fraction, which is an ejection fraction less than 40%. For the students, an ejection fraction is basically once you fill the LV with, say, 100 cc's of blood, with one squeeze, how much of that blood goes out. So amount of blood that comes in versus the amount of blood that goes out. So that's a proportion that we talk about as ejection fraction. So in patients who have preserved heart failure, your ejection fraction is either normal, which is about 50%, or somewhere above 40% at least. So this is called heart failure with preserved ejection fraction. So we're going to talk about management of patients with heart failure, starting with the classification system that I told you about, the staging, A, B, C, or D. I'm not going to talk so much about stage A because it's mostly outpatient heart failure treatment. These patients haven't developed heart failure yet. It mostly is the job of the preventive cardiologist to make sure that you don't develop heart failure. So we're going to talk more about stage B, which is patients you, say, get admitted for some osteoarthritis with some knee effusion you're going to tap, and then you, for some reason, auscultate this patient, and you say, oh, the patient has S3, S4, I'm going to get a echo, and then you see an ejection fraction that is less than 40%, but they haven't developed any other symptoms of heart failure. They don't have pedal edema, they don't have any other symptoms of heart failure. Those patients are stage B patients. And so we're going to talk a little bit about stage B patients, but mostly about stage C and stage D heart failure patients. So stage B heart failure patients are patients who don't have symptoms. They may have asymptomatic valvular disease that is causing the heart failure. They may have a prior MI that is causing the heart failure. In any case, the goal of the therapy in these patients is to prevent heart failure symptoms. They haven't developed it yet, and you don't want them to develop it. And then you are trying to prevent further adverse cardiac remodeling in these patients by using drugs like ACE inhibitors or ARBs and beta blockers as you find appropriate. In very, very small percentage of these patients who have stage B heart failure, you're going to have advanced heart failure therapies like ICD or CRT. Most of these patients don't require advanced heart failure therapies. They're going to go with just drugs alone, medications alone. All right, so stage C heart failure, your therapy goal is to control symptoms, improve their quality of life, prevent hospitalization. We're going to talk about that throughout our talk today, and prevent mortality. And that's the same for either HFpEF or HFrEF patients. And part of this includes educating the patient about medication compliance, diet compliance, and things like that. So we're going to then treat them with medications like diuretics, ACE inhibitors, or ARBs. We're going to talk about all these things, beta blockers, aldosterone antagonists. And then for selected patients with HFrEF, you can offer them advanced heart failure therapies like CRT, ICD, and if you think that the patient is having ischemic causes for heart failure and cardiomyopathy, you're going to offer them revascularization. And if they have valvular disease, you're going to offer them surgery as appropriate. So we're going to start off with what is the initial workup of heart failure and which patients need which of these things. You don't have to do everything for every single heart failure patient, so we're going to talk about that. So every patient who has a diagnosis of heart failure does require a 12-lead ECG. So that's a class 1 indication. You have to do a 12-lead EKG on all your patients to see if they have T-wave inversions, if they have left ventricular hypertrophy, all those kinds of things. Chest X-ray in a new onset heart failure patient to see if you have pulmonary edema, volume overload. Echocardiography in patients with a new diagnosis of heart failure, because that's one of the ways you're going to diagnose this patient with heart failure, and you're going to categorize them as either HFpEF or HFrEF, right? And MUGA in some patients where you have poor echo windows or the echo wasn't adequate enough to actually give you an ejection fraction, then you can do a MUGA scan. A repeat echo is usually only for patients who have significant change in the clinical status. Every time a patient gets admitted with a heart failure decompensation, every 2 weeks some of our patients get admitted, you don't have to keep repeating that echocardiogram, only if there is a significant change in the clinical status, which means that some patients are really sick, but they have been sick forever. They've been having the same status for the last 6 months. Every time they get into the hospital, they're going to be decompensated. That doesn't mean that every time you have to repeat an echocardiogram, okay? And then if they have a new onset heart failure or a new diagnosis of heart failure, not necessarily every patient requires an assessment for ischemic cardiomyopathy. Ischemic cardiomyopathy assessment is based on your suspicion of coronary artery disease underlying heart failure, and that is reserved for patients that either have anginal symptoms, or if you did an echocardiogram and the echo shows regional wall motion abnormalities, or they have T-wave inversions on the EKG, or exertional dyspnea that you think is not really just heart failure alone, but somehow you think that there is a coronary artery disease component behind that, then you can actually do either a stress test to assess their coronary artery disease risk, or you can do a cath to look at it. So again, not every patient that gets admitted to the hospital with a new onset heart failure requires a cath. That's some kind of a illusion that we have in our mind. It used to be a thing of the past, but the newer guidelines in 2013 and 2016 says that you can do it if you suspect coronary artery disease. Okay, so when we do NT-proBNP in our patients with heart failure, there are several things that I want to talk to you about. So NT-proBNP, the first thing is, remember we talked about stage A heart failure, right? The first stage where patients haven't developed heart failure, they have risk of heart failure. They don't have symptoms, their EF is normal. Those patients, the recent studies have shown that if you actually follow their NT-proBNPs, if they have risk factors for heart failure, if you follow their NT-proBNPs, that can prognosticate whether they are going to develop a heart failure in the future. So you can follow their proBNPs, like yearly proBNPs, when they come to your internal medicine clinics, and when their proBNP goes up, you can actually assess them for heart failure. So proBNP can be a prognosticator of heart failure readmissions and mortality. At discharge, if your proBNP is more than 400 to 500 picogram per ml, these patients are going to get admitted more often. So watch out for these patients. You typically want to bring their BNPs down, but I'm sure that you can't always bring all the proBNPs below 400 because many of our patients come in with 22,000 or 25,000. But these patients are at high risk for getting readmitted or for mortality. So sometimes patients with low EF can have normal proBNP, and that's not unusual. If you control their volume status adequately, their proBNPs may be normal. ProBNP goes up with age, goes down with obesity, goes up both in HFpEF and HFrEF, more in HFrEF than HFpEF. And ProBNP can go up with large pulmonary embolism as well as RV systolic dysfunction as well. ProBNP is not recommended as a tool that you can use to alter your treatment or titrating your medications based on that proBNP. And I've seen this multiple times that you get 4 or 5 proBNPs doing one admission every day. You get proBNPs. I'm not sure if that is recommended or if there has been any studies that have shown that during a hospital stay you can follow proBNPs and adjust your medications. So that's something that you want to think about. The prognosticating proBNP is the first BNP that you get when the patient gets admitted to the hospital, not the ones following that. All right. So once you do that, you are thinking about doing some invasive evaluation, and I'm going to talk about right heart catheterizations in patients with heart failure. We are, as a cardiologist, we in this institution are notorious for doing less right heart caths than many of the other institutions, but there is a time and place to do right heart caths in patients with heart failure. So if you have a patient that's admitted with respiratory distress and you don't have a good assessment of their intracardiac filling pressures with your clinical assessment, or they have impaired perfusion that you can see in your clinical assessment, but you can't see what their filling pressures are, you can actually do a right heart cath to figure out what these filling pressures are and cardiac output and things like that. Also, once you've diagnosed a patient with heart failure and you've started treatment, but with empiric treatment, the patient hasn't had any improvement in symptoms and the symptoms are persistent, then you can actually do a right heart cath to figure this out. And one of those conditions is where a patient's renal function goes down with the treatment for heart failure, worsening renal function with therapy. If you're using parenteral vasoactive agents, if your systolic blood pressure remains low despite therapy, these are some of the conditions where you can use a right heart cath to streamline your medical management to make this patient get better and get out of the hospital as soon as it's possible. When ischemia is suspected, you can get a coronary angiography, as we talked about before, and you don't always have to start with coronary angiography. If your suspicion is like not as like the patient did not have a previous CAD, they don't have angina, but there is some T-wave inversion on the EKG, you could do a stress test to begin with and then go from there. You don't always have to start off with coronary angiography. So this is the pathophysiology of HFrEF, and there is an initial insult to the myocardium, and then there is a response to that insult, which could be either a beneficial physiological response, which could include natriuretic peptides like BNP, ANP, or it could be a pathophysiological response like the increased renin-angiotensin system, the sympathetic nervous system, and things like that. So how a patient presents to you and when they present to you, what their symptoms are, depends on the balance between the beneficial physiological responses and the pathophysiological responses. So how this plays out is how patients present to you. And most of our medications, if you take a look at it, they're all based on blocking these pathophysiological responses or improving the beneficial responses that are, for example, sacubitril valsartan is to improve neprilysin, the actions of neprilysin. So if you look at beta blockers, they block the sympathetic nervous system. So all our medical therapy is based on these two responses and the equilibrium between them. So here are some medications that we use for heart failure treatment, and I've separated them out into what improves symptoms, what improves hospitalization, rehospitalization, or decreases rehospitalization, and what decreases mortality. So diuretics are good for symptom management, but they're not going to reduce mortality, and they're not going to reduce rehospitalizations either. ACE inhibitors do all three of them. As you know, beta blockers have mortality benefit, reduce symptoms, and reduce rehospitalizations. We're going to talk a lot about aldosterone antagonists today. They do all three of them. Digitalis, notoriously famous for maybe even increasing mortality a little bit, but they actually reduce rehospitalizations for sure, make the patient feel better. Nitrates have all three effects. Arni, the new medication Entresto, which is sacubitril valsartan, as I told you before, improves mortality as well as controls symptoms and reduces hospitalization. Ivabradine, on the other hand, improves quality of life. Their exertional tolerance gets better, but their mortality doesn't get better. This is not something that has been shown in the studies. ICDs neither does improve the symptom or reduces hospitalization. They only decrease mortality. So when you talk to your patients about ICDs, make sure they understand that once they get an ICD, it's not going to be magic that they're going to feel better. CRT, on the other hand, a cardiac resynchronization therapy, which is by VICDs, will improve mortality, reduce hospitalizations, as well as improve their symptoms. So I want you to pay attention to this slide. This is the relative risk for mortality reduction with each of these agents and the number needed to treat. Which of these, you treat the least number of patients and you get the big bang for the buck? Which one? You guys know how to interpret number needed to treat, right? Hopefully. Students? Oh, wow.
Aldosterone antagonist.
Okay, aldosterone antagonist. Because you only treat 6 patients to save 1 life, right? So number needed to treat is interpreted in the way that these are the number of patients you need to treat to save 1 life. So aldosterone antagonist is the least number needed to treat, and therefore the most efficacy and the most bang for the buck. And it is one of the cheapest medications that is also available out there for heart failure management. So when we talk about the economics of heart failure, I'll come back to this, and I'll show you some of the data there. Okay, so when you have a patient with stage B to stage D heart failure and NYHA class 1 to 4 exertional status, and then you start off with the ACE inhibitor and ARB, ACE inhibitor or ARB, and I'll tell you when you should use both, and a beta blocker. And then if they are volume overloaded, you're going to diurese them. If they are African Americans, you want to add hydralazine and nitrate to their regimen to improve their mortality benefit. And if they are NYHA class 2 to 4, you're going to add an aldosterone antagonist. This is the pathway by which you're going to start medications on your patients. So beta blockers are indicated for any patient with a symptomatic or asymptomatic heart failure with an ejection fraction less than 40%. You're going to use only one of those medications that were used in the clinical trials, and this is one of my pet peeves that I see. Some of our residents will use metoprolol tartrate to treat a patient with heart failure, which was never tested in the clinical trials. And you want to start it when the patient is euvolemic, when you're no longer using an IV diuretic, and you titrate them every 2 to 4 weeks as long as their blood pressure and heart rate tolerates it. Most of these trials were done with the heart failure beta blocker up titration until the heart rate dropped below 60 or the systolic blood pressure dropped below 90. And if you are having problems up titrating your beta blocker, you can stop it at that point in time, meaning like stop the up titration at that point in time, keep the beta blocker at that dose, and up titrate all the other medications that you have. So which beta blockers were used? Only bisoprolol, Coreg, and metoprolol succinate were used in the clinical trials for heart failure. Metoprolol tartrate, which is the short-acting form, was never used in the clinical trials, and therefore, if you are treating a patient for heart failure and systolic dysfunction, you don't want to be using that. For diastolic dysfunction, you can use any of them because none of them actually has been shown to be beneficial anyway. All right, so which ACE inhibitors? Pretty much all ACE inhibitors can be used, and all of them have been tested in heart failure patients. These are some of the mean doses that were achieved in these heart failure patients. So if you look at lisinopril, many of our patients are at 2.5 and 5, right? So if you look at the mean dose that was achieved, which means that some of these patients were getting quite a high dose of lisinopril, is about 35 milligrams per deciliter. So be aggressive in up-titrating your medications, especially ACE inhibitors. So ARBs, when do you use ARBs? ARBs can be used when you are having allergic reaction to ACE inhibitors like angioedema. Cough is not really an allergy, but because the bradykinin secretion, you can actually have cough with ACE inhibitors, then you can use ARBs. You can use ARBs as an alternative, as a first-line alternative to ACE inhibitor in some cases, and you can add an ARB to an ACE inhibitor if your patient actually has some kind of condition where you cannot use aldosterone, like their potassium is always high. In that case, even ARB might be kind of tricky, but where you can't use aldosterone, you can add an ARB to ACE inhibitor. So these are the ARBs that were tried in the clinical trials, and these are the mean doses that you can see here on this slide. So aldosterone antagonists, very important, and you start these in patients who have NYHA class 2 to 4 if their EF is less than 35%. But if they are only NYHA class 2, then you need to have one of these other things, which is either a history of prior heart failure hospitalization or an elevated BNP. In these conditions, you can start aldosterone inhibitor in patients with NYHA class 2 heart failure. So their creatinine should be less than 2.5. And their potassium should be less than 5 when you start these patients. When you start these patients, you want to bring them back within a week for a potassium measurement first time, and then you actually follow them at a decent interval to make sure that your potassium and creatinine is within acceptable limits. So these are the two aldosterone antagonists that we commonly use, spironolactone and eplerenone. What I want to point out to you on this slide is the maximum dose of spironolactone used in trials is 25 milligrams daily. It's not 50 milligrams, it's not 100 milligrams. Those doses are meant for ascites patients for diuresis purposes. It's not a reverse remodeling agent when you use that much of spironolactone. You could use it, but it wasn't tried out in the clinical trial. So your maximum dose is 25 milligrams daily. All right, so aldosterone inhibitors are the only heart failure medication that has been shown to have at least some benefit. This is not even a mortality benefit, some benefit in patients with HFpEF. All the other medications, we've not seen any significant difference between patients who get a medicine versus a placebo when you take HFpEF patients. HFrEF patients, we talked about all these agents, but patients with preserved ejection fraction don't benefit with either with mortality benefit or rehospitalization with most medications. But aldosterone antagonists, this was recently added in 2018 to the recommendations based on a retrospective post-hoc analysis of a trial that was done with spironolactone. And then based on that, they recommended that we use this. The only reason they said that was the entire cohort did not have a difference, but they analyzed it by region, and they found that patients who were added to the trial from Russia and Georgia did not have any benefit, but the patients in the US had benefit. So they therefore recommended this as an additional tool for patients with HFpEF. So hydralazine and nitrate, you can use it in African Americans. You want to add it to the existing medications, which is ACE inhibitors or ARB and beta blockers, and then you want to add hydralazine and nitrate to them. Because in that particular subset of patients, there was a mortality benefit for using this drug. And hydralazine nitrate can be used as an alternative in any patient who has either a contraindication for using ACE or ARB, or their renal function is quite abnormal where you can't use it. Then you can use hydralazine plus nitrate. So tell me if you can use, if I'm right, can I use IMDR 30 milligrams plus hydralazine 25 milligrams TID? Okay, good. So Mazen is right. The trial was based on TID dosage of isosorbide dinitrate, and therefore there is some kind of benefit of adding the drugs at the same time and taking it at the same time. So therefore, you're not supposed to use a long-acting nitrate, and short-acting nitrate would be the way to go. And it doesn't make sense anyway if the patient is going to take hydralazine 3 times a day. You're not going to spare them any discomfort by adding that IMDR as a one-time agent, right? So digitalis decreases hospitalization, improves symptoms, but there are multiple studies that's still controversial, and we actually published one of them from here that shows that digitalis increases mortality, can increase the risk of arrhythmias, and can cause VT storms in patients with heart failure and have devices on them. But we still use it because it's quite a beneficial drug in reducing symptoms. At least in short periods, I use digitalis in my patients. The key about using digitalis is the therapeutic window of digitalis is quite narrow. So can somebody tell me where is the therapeutic benefit and below which it doesn't work and above which it increases mortality? Residents? Oh. Okay, it's 0.8 to 1.2. If you send the patient's blood out for DIG level, right? The DIG level will say toxic levels are about 3 point something, 2.8 or 3 point something. But the actual mortality goes up when it hits 1.2. So the therapeutic window within which it works is pretty narrow. It's only between 0.8 and 1.2. So be careful when you use DIG. So the DIG doses are between 0.125 and 0.25. It can be used in patients, especially who have concomitant atrial fibrillation, for controlling their ventricular rates when they have AFib. And as I said, it decreases hospitalizations. Okay, so this is the new kid on the block, neprilysin inhibitor, which is basically neprilysin is an agent that breaks down these agents, these neurohormones into inactive fragments. And one of them is BNP, natriuretic peptides, right? So when you break down BNP, your beneficial effect of BNP goes down, and therefore by inhibiting it, you actually make it better. But always sacubitril, which is the neprilysin inhibitor, is tagged with an ARB. Why? Because one of the things that neprilysin breaks down is angiotensin II. So when you stop neprilysin from, if you use neprilysin inhibitor, your angiotensin II levels are going to go up, and so your blood pressure is going to go up, and so your negative remodeling is also going to go way up. So you always have to use it with an ARB. So that's why this drug is sold as Entresto, which is neprilysin inhibitor, which is sacubitril plus valsartan. Okay, so this is the landmark trial for neprilysin inhibitor and sacubitril plus valsartan, which is called the Paradigm Heart Failure Study. that showed that there was a decreased risk of mortality, decreased risk of hospitalization, as well as the combined endpoints. And therefore, we now recommend using Entresto for all these patients. So I'm going to show you the recommendations for that according to the guidelines. Now, this trial is testing another drug called ivabradine. How many of you guys think about ivabradine during your ward rotations treating a patient with heart failure, or in your outpatient rotations treating a patient with heart failure? Has anybody added ivabradine? Wow, not one of you. Interesting. Okay, so this is also recommended in the current guidelines, and so you want to make sure that if your patient's heart rate, and I'm going to go over that, is above 70 on the maximum dose of beta blocker that they can tolerate, ivabradine improves their exercise tolerance and improves their symptoms and reduces rehospitalizations. So you want to keep that in the back of your mind. So here are the guideline indications. So this was not in the 2013 guidelines. It was an update published in 2016, which is the slide that I have here, but it was formally made into guidelines in the 2017 update of the 2013 guidelines. So ACE inhibitor or ARB or ARNI can be started as a first-line agent for patients with heart failure and low EF, which means that when you have a new onset heart failure patient, right, and this is the first time they have an EF less than 35%, you're going to start medications. You don't have to start with an ACE or an ARB and then change it to ARNI. You can actually start off with Entresto and then add beta blocker to it. But if you already have a patient that is coming to your clinic with ACE inhibitor or ARB and they're able to tolerate that medication very well at decent doses, then the recommendation is to switch them to Entresto. Okay, make that clear. It's not adequate. You leave them on an ACE or ARB if they are tolerating it well. The current guideline is to switch them to Entresto. And ARNI should not be administered concomitantly with an ACE inhibitor within a 36-hour period. So if you're going to stop your patient's lisinopril and start the Entresto, you have to wait for 36 hours before you give them the dose. Or the other way around. If they took Entresto, then you have to wait for 36 hours before you give lisinopril. And ARNI should not be administered in patients who have history of angioedema due to any cause, including ACE inhibitors or ARBs. And then ivabradine is beneficial to reduce heart failure hospitalizations, as I told you before, in any patient with symptomatic, stable, chronic HFrEF with an ejection fraction less than 35% who are already receiving GDMT. So this is not, I actually saw one of my relatives that was referred to me from India for heart failure management, and the only medication that she was on other than Entresto was ivabradine. She was not on a beta blocker. That was not how these trials were done. In these trials, the beta blocker was, ivabradine was added on top of the beta blocker. So on beta blocker, if they are still having a resting heart rate more than 70 beats per minute, then you can add Entresto to that patient. So maintenance of goal-directed medical therapy during hospitalization. This is another controversial topic for many of us. In a patient who is experiencing a decompensation of HFrEF and getting admitted to the hospital, it's recommended that you continue the goal-directed medical therapy in the absence of any hemodynamic instability or contraindication. So if a patient is already on a beta blocker, coming into the hospital with heart failure decompensation, you don't necessarily have to stop that beta blocker. You don't want to start the beta blocker unless the patient is volume, compensated with regards to their intravascular volume, but you don't have to stop it necessarily. When do I stop a beta blocker when a patient comes in with heart failure decompensation? I stop it when the patient requires an inotropic agent. So if you're going to start them on dobutamine, you don't want to add a beta agonist and a beta antagonist together. So then you stop it. But otherwise, you don't have to stop beta blockers. Initiation of beta blocker therapy is recommended after optimization of volume status, like I told you before, which actually is defined in the guidelines as discontinuation of intravenous diuretics, vasodilators, and inotropic agents. So you cannot be on inotropic agents, IV vasodilators, which is nitroprusside or nitroglycerin, or IV diuretics. Diuretics in patients who are admitted for heart failure decompensation. I know you guys know how to handle diuretics, so I'm not going to go over the other guideline factors that were mentioned about what dose of Lasix to use, when to use metolazone, and all those things. The one thing I want to actually show you is I have a low threshold to add either IV dobutamine or dopamine to existing Lasix regimens to improve their renal function and renal blood flow and to improve the diuresis. So this is something that you want to bring up to your attending when you're rounding and say, hey, do you want to start a low-dose dobutamine or dopamine in this patient to get the diuresis better? So parenteral therapy in hospitalized heart failure patients, we always think about adding dopamine or dobutamine, but there are several other things that you can do to your patients to improve their acute decompensation. One of them is vasodilators, nitroglycerin or nitroprusside. You have to be careful when you use nitroprusside in patients who have a bad kidney function because they can have cyanide toxicity. But Neseritide, nitroglycerin, and nitroprusside can be used in your patients who have decompensated heart failure, in addition to all the other drugs that you already use, which is dopamine, dobutamine, and milrinone. All right, so here are the recommendations. This is all the same things that I told you before. It's just given to you in a format of what the level of recommendation was. So most of these are class 1, and then there are some class 2As and class 2Bs here. We went over most of these already. And the one thing I want to show you is ultrafiltration can be used in patients who cannot tolerate diuresis and their blood pressures are pretty low. Then you can use ultrafiltration to volume optimize these patients. All right, so this is another big deal right now is like, what do you do with your medications when the patients get discharged from the hospital, right? This is being monitored by several entities within ACC-AHA, within our hospitals, within CMS, in different ways. And a lot of our reimbursement actually it can depend on this, and therefore I want you to pay attention to some of these things. Before hospital discharge, at the first post-discharge visit and subsequent follow-up visits, the following should be addressed. So if you don't have GDMT for some reason, either they couldn't tolerate one of the agents because your blood pressure was super low, or they had allergy to one drug, then you stopped it, you want to optimize that medication, make sure you go back there and address that either before discharge or at the first visit. And you assess their volume status and blood pressure and adjust heart failure therapy, optimize chronic oral heart failure therapy, check the renal function electrolytes, especially if you started the patient on spironolactone recently as a inpatient, you want to check it as an outpatient. Management of comorbid conditions. If you look at the current guidelines, there's a new section for how to manage blood pressure, hypertension in patients with heart failure. And I didn't put that in because it makes total sense to do it, but there's a new section on it that says if you have a patient with heart failure, their systolic blood pressure can never be above 130 millimeters of mercury. Okay? So heart failure patients' systolic blood pressures always have to be less than 130. And then you provide heart failure education. And if your patient is somebody who keeps coming back to the hospital over and over and over again, I'm going to show you some data on this too, you want to address their goals of care and whether they want to be a hospice patient, because they may not realize that heart failure is as sick as a condition as cancer. So you want to make sure that you have educational material that teaches them that their life expectancy is very limited, and if they want to actually pursue palliative and hospice care, which is very important because then it will actually prevent rehospitalizations to the hospital and improve their quality of life as well. So you want to include a multidisciplinary team in your heart failure management of patients. A recommended follow-up visit after a heart failure hospitalization is within a week to 2 weeks, and that's something I want to bring it up because we have a new heart failure team, and I've brought in all the nurse practitioners that are going to be part of it here. I'm going to introduce them to you. So we're going to make sure that all our patients that get discharged with a certain EF get seen in the hospital, it's seen in the outpatient transition care heart failure clinic within a week. And then we want to actually use clinical risk prediction tools and biomarkers to make sure we identify the higher risk patients who can get rehospitalized or can have higher mortality. This is something that the ACC-AHA Get With The Guidelines recommends that you address as an inpatient. There is actually how many of you know what Get With The Guidelines is? Okay, so there is a new endeavor within ACC-AHA called Get With The Guidelines, and each hospital is being monitored by ACCHA if you want to be a part of it. And then you have a ranking system that anybody can see in the public. You actually go and see which hospital is good for heart failure management, and it's going to show you this hospital is graded rank F or A plus or whatever it is. So that is one of the criteria for that is whether you address CRT and ICD when they got discharged. Either you gave them an appointment with an EP doctor, whether you actually put it in, or you talk to the patient, you document it. It's actually counted as a point towards the hospital, favorable to the hospital. So you guys all know the recommendations for ICD therapy, ejection fraction less than 35%, and they're NYHA class 2 or more after 3 months of medical management for their heart failure, or they have ischemic cardiomyopathy, did not get a revascularization done, in which case you only wait for 40 days on optimal medical management, and then you give them an ICD. This has to be addressed at least in your note for us to get credit for this. And then indications for CRT, you guys know that if your ejection fraction is less than 35%, you are NYHA class 2 or more, and your QRS duration is more than 120 with the left bundle branch block, or 150 with the right bundle branch block, or non-specific intraventricular conduction delay, you're a candidate for CRT implantation. The only exception to that rule is if your NYHA class is 3 or more, and you're a right bundle branch block patient with a QRS duration 120 to 150, you have a class 2B indication for those patients. Otherwise, you stick to this number, 120 or above for left bundle branch block, and 150 or above for right bundle branch block, you'd be fine. So make sure you address these things when the patients are discharged from the hospital. And then the last thing is stage D refractory heart failure. These are patients that keep getting admitted to the hospital. They have very poor quality of life. In these patients, your goal is to either offer them advanced measures like VADs or transplant, or you talk to them about palliative care and hospice. Okay, so that's something that you want to address because that'll help the hospital as well. So these are clinical events and findings which are useful for identifying patients with advanced heart failure. I'm showing this to you because we as physicians and even cardiologists are sadly not paying attention to the timing of referral for advanced heart failure therapies. So advanced heart failure therapies, you don't have to wait till the patient is crashing and burning, getting admitted to the ICU with cardiogenic shock before you refer them for VAD, because at that point in time, the VAD guys cannot do the VAD anyway, okay? And this is a common referral that I get, like, oh, this patient is on 4 different pressors, we want to put a VAD in. The patient is going to die on the table if you try to put a VAD in that patient, right? So you want to refer them much ahead of time. So if you have any of these, think about referring your patients to an advanced heart failure center for advanced heart failure therapies. If they have had more than 2 hospitalizations or ED visits for heart failure in the last 1 year, if they have had progressive deterioration of renal function on the medications that you started them on, weight loss without other reasonable causes, intolerance to ACE inhibitor due to hypotension or worsening renal function, intolerance to beta blocker due to worsening hypotension or heart failure symptoms, frequent systolic blood pressure less than 90. This is many of our patients, and we don't think about putting in VADs in these patients until it's too late. Persistent dyspnea with dressing or bathing on optimal medical management, inability to walk 1 block on level ground due to dyspnea or fatigue, recent need to escalate diuretics to maintain volume status, often reaching daily Lasix dose of more than 160 milligrams per day, and or use of supplemental metolazone therapy. How many of your patients are on metolazone and not been ever referred to an advanced heart failure therapy management? Progressive decline in serum sodium, usually less than 133. This is another thing that I see oftentimes in our patients, and frequent ICD shocks. In these cases, think about referring them early to an advanced heart failure center for management with advanced heart failure therapies. So mechanical circulatory support is beneficial in selected patients with stage D HFrEF, in whom definitive management or cardiac recovery is anticipated or planned. It's a class 2A indication. If you have a patient that is a bridge to recovery and they are actually crashing and burning, but you think they are a reasonable candidate to bridge to an advanced therapy, then you can put in non-durable mechanical circulatory support like Impella and all those things. And then durable MCS for patients who have prolonged survival for carefully selected patients as either destination therapy or as a bridge to transplant. So this is the number of VADs that have been implanted at least until 2013. Both the number of centers that are implanting VADs and the number of patients that are getting VADs are going up every year. So you want to make sure that your patient gets that privilege and benefit of being referred to one of these centers, and you're not treating them in a suboptimal manner, okay? So this is the intermax criteria for VADs, and so worst is 1, and the best is actually 7. So if most of the patients right now are being referred to VAD centers between 1 to 4 intermax criteria. So if you read this critical cardiogenic shock, as I told you, is the most common reason right now VAD patients are being referred to VAD. I'll tell you why it's a bad idea. If you look at this graph, if your intermax criteria is here 4 or less, your mortality, even with the VAD, is pretty bad. So you want to actually refer them earlier when they are here, somewhere between 5 and above, so their improvement in quality of life is earlier, their survival is a little longer as well. So just pay attention to this and refer them early in the course. So now coming back to our own data. So where do we stand in the management of heart failure in comparison to not to Harvard or Yale, but other hospitals in the area here, right, in the south? So look at this. This is us, right? So our heart failure rehospitalization within 30 days went down sometime in 2018 and then has come back up and has stayed up since then. Even though we've been trying to see transition care patients in the clinic within the first 7 days, we are currently the highest rehospitalization rate between Monroe, which is actually the saddest part, Arkansas and Lake Charles and Mississippi. Private hospitals do better than us, okay? So we need to man up and do something better for our patients and decrease the rehospitalization rates. So this is the rehospitalization rates after CMS actually brought in multiple programs to reduce hospitalizations. If you look at it from the time they initiated the program, which is somewhere here, to about 2012, there was a significant drop in rehospitalization rates, not only for the targeted conditions like heart failure and pneumonia, also for non-targeted conditions, which means that when you actually target these patients to prevent rehospitalizations for heart failure, you also make sure they don't get rehospitalized for other causes. So it actually is beneficial for the whole healthcare system in general. But somehow, after 2012, everywhere, not just here, our rehospitalization rates have plateaued, okay? And why is that? And I'm going to show you why is that based on our example. So before that, let me show you this. So between HFrEF and HFpEF, are there any changes or differences in mortality or rehospitalization rates? The amount of diagnosis of patients with HFpEF has gone up. So this is the total heart failure patients diagnosed in these years from 2005 to 2010. And you can see slowly the HFpEF proportion has significantly increased in the last 5 years. But although in-hospital mortality seems to be higher in patients with HFrEF than HFpEF, if you follow up these patients, outpatient mortality is about the same for both HFrEF and HFpEF patients. So pay attention to your HFpEF patients. Unfortunately, there is not much we can do about it, but close monitoring of these patients are necessary, and at least you can correct things that you can correct, like ischemia. If they have AFib, refer them for aggressive AFib management and rhythm control. So those things can be done, and rhythm control in AFib patients with HFpEF has been shown to be beneficial to these patients. So at least do the things that you can do to prevent them from dying early. So this is our data, and this is why the heart failure rehospitalizations have plateaued. What did I tell you was the cheapest drug that we have that prevents rehospitalization and mortality the most? It's aldosterone inhibitor. Look at our rate of using aldosterone inhibitor. We've been fail, somewhat mediocre, passed one time, and then failed again. So this is in comparison to national average of using aldosterone inhibitors. We're pathetic, okay? And that's not just for that. Look at many of our agents, we're doing really poorly at discharge. Many of our patients are not going home with beta blockers, not going home with ACE inhibitors or ARBs. They don't have any recommendations on ICD or CRT therapy. So you can see any of these things, there are very few green. I think one of them is post-discharge appointment. We're really good at giving that to patients. And that partly may be because of some of the things that we've changed in the last few years. We're really, this one is my favorite, measure LV function, of course, because every time patients get admitted to the hospital, you get an echocardiogram on them. So, but otherwise we do really badly on the things that can make a difference in the patient's quality of life and survival. So pay attention to these indicators and see if you can improve them. So hospital readmissions, why are they important? Because they are a reasonable surrogate for quality of life. They are preventable, and they are associated with short-term mortality. So maximum rate of penalty from Medicare, if you have a certain number of readmissions, is 1 to 3%. It was 1% in 2013, and now it's 3%. So on an average, the amount of penalty that the hospitals have paid up to CMS has gone up from $290 million to $528 million. So our hospital is actually one of them. We have given Uncle Sam a lot of money. Okay, so I think in 2017 is the last one I remember, is 2-point-some million we had to pay penalty for our rehospitalization rates. So be careful about discharging patients very early and make sure you discharge them at the right time. So rehospitalization mortality, this is why rehospitalization is important and not important. So if you look at the graph on the right side, it shows at a patient level, every time you get admitted to the hospital, your survival goes down and your mortality goes up, right? So this is the first admission. The second admission, your mortality goes up. The third admission, your mortality goes up. So every time you get rehospitalized for heart failure, your mortality goes up. So for the patient, it's really bad, okay? Unfortunately, what is shown here is that when hospitals try and prevent rehospitalizations, that hasn't totally panned out into reducing mortality for that hospital. So for example, here is, this is monthly change in readmission. So this is 0, right? So anything above here is positive for readmissions. And this is 0 for mortality. So anything to the left of that is reduction in mortality. So as you can see, there are some hospitals like this one here, they have actually done very poorly because their rehospitalization rates are up and their mortality rates are up. But if you look at this one here, they've done really well. Their rehospitalizations are down and their mortality is down. But look at this one here. Their rehospitalization rates are down, but their mortality is still up. So it hasn't panned out in a system-wide manner from reducing rehospitalization. We haven't been able to translate it to reducing mortality. So that's something that we're still debating about how to best do. So the economics of heart failure in 2009, the estimated direct and indirect cost of treating heart failure patients was about $37 billion. Okay? Hospitals receive about $6,000 for each admission for heart failure. I don't know how many of the med students and residents know this. You can do CT scan and a right heart cath and a left heart cath, order 10 echoes, put a VAD in, you do whatever you want, you still get $6,000 for a heart failure hospitalization, right? So it's a DRG basis. The only way you can change it is actually going back here. There is something called a case mix index here. The case mix index tells you, on an average, how many comorbidities do your patients have. So each patient you treat, you have 10 comorbidities or just one comorbidity. They average it and give you this score called the case mix index. If your case mix index is up, your payment will be up for the same DRG. If your case mix index is lower, you get lower pay for the same DRG. Unfortunately, we don't document our comorbidities well in our notes, so our case mix index is lower than some of the hospitals in this area that treat much healthier patients. So we get paid less than some of these private hospitals in the region that actually treat patients that are much healthier than us. So we need to be very cognizant of that fact and make sure you document your comorbidities so our case mix index goes up. Okay, so 25% of heart failure patients get readmitted within 30 days. That's not our average, but it's an average for the nation. So approximately $11,000 is spent for the initial admit, although we get only paid $6,000. And when the patients get admitted a second time, we pay $13,000, $2,000 more than the first admission. So to see how rehospitalization can matter in small bits and pieces to every institution, right? So let me show you this. So this is our any cost readmissions a few years ago. It was about 2.5 years ago, I think. So if you see here, there were about 200 and some readmissions. I think this was over a 1 or 2 year period. This is not really a 30-day readmission. It's actually any readmission within the 1 year, right? But if you look at it, look at this. There are three or more admits, about 15 patients. So 15 patients had more than 3 admits in a year. And then about 1 patient each actually had more than 5 admits and 6 admits and 8 admits. So what do you do with these patients? What I hear? Yeah, you can send them to us, but these patients, typically should get some kind of education about their life expectations and quality of life, and probably have a talk about hospice care and all those things, right? So you make sure you do that for these patients here. So this is one of the other pet peeves of mine. So if you order any of these tests as an inpatient, you get paid less. Because of the way the DRG works, you get paid less. So the yellow bars are the amount of payment you would receive for any of these tests as an inpatient versus you order the same test as an outpatient, okay? So for right heart cath or left heart cath or even echocardiogram, you get paid less than $800 for an echocardiogram as an inpatient while you get more than $2,000 as an outpatient, right? So as much as possible, you want to optimize, I'm not saying that you shouldn't get echo on your patients that really require an echo. But if they don't need an urgent echo that can be ordered as an outpatient, then you would get paid more for the same echocardiogram. So something to think about. So I'm going to skip this slide in the interest of time, so I only have 2 minutes. So this is a very simple graph that tells you what is a good therapy for not just heart failure, but for any medical condition, right? So WHO says any interventions that are costing up to 1 GDP per capita, which is about $59,000, by the way, in the U.S., in the U.S. for one additional quality of life should be considered cost-effective, and anything that is more than 3 GDP is very expensive, right? So if you look at this here is efficacy, okay, and this is the cost. So anything above this line is very expensive, and anything to the left of this line is not efficacious. It's not if it's not effective treatment. Okay, so if you look at that, if you draw this diagonal here, anything below this line are the medications or therapies that have the best bang for the buck. So it's either very effective, even though it's slightly more expensive, or they are very cheap and effective, or they are somewhat effective but not very expensive, right? So that line, below that line, is where you want to keep your costs for any management of any disease process, and that's where we want to keep it for heart failure. So with that, I'm going to introduce 3 of our nurse practitioner and our heart failure nurse coordinator in the back. So we are going to start an inpatient rotation for heart failure from October 1st. So we have some criteria that we're going to publish and put up in all the team rooms for which patients should be referred automatically to the heart failure team, and we'll be staffing, cardiologists will be staffing it, supervising one of our nurse practitioners to do this, and we'll help you out with achieving these goals that we talked about today. And you have to be cognizant of these goals, but we'll be able to help you out at the time of discharge to achieve those goals as well. And I'll take any questions.
I have a couple of, maybe I could ask you a couple questions. One is, or clarifications. So it was great that you showed our chart of optimal therapy. It is important to understand that you don't have to put everyone on every medication, but you should indicate why you're not putting them on one of the indicated medications. And so, as we're being compliant, you simply need to understand what's best for your patient, but communicate that. So your notes, your discharge notes, should demonstrate why you're not having that. Now, as an interventional cardiologist, I need to help update the current guidelines because this last year we've actually had an additional therapy, not just resynchronization, but I think everybody has seen that mitral regurgitation, particularly due to enlargement of the left ventricle, now in the setting of optimal medical therapy, has had a therapy, mitral clipping, mitral valve clipping, that actually improves not only symptoms but mortality, and that was one thing I noticed wasn't there. But I want to make sure that we recognize that.
Yeah, so the first point Dr. Bailey was making, that is absolutely correct. There are times that you can't use some of these medications, and that's why what we're trying to do is in the O2 version of EPIC, create a discharge order set that allows you to say, I'm not adding this medicine because I have this condition, right? So you want to document that not only in your notes, but also in the order sets. That makes it easier for people who go through these for quality assessment later on to see very clearly why you haven't put somebody on some medication. The point about mitral clips, I forgot, I did not put that slide in there. So under the invasive procedures, not only I didn't talk about mitral clips, I did not talk about surgeries as well. Clearly, there is a role for cabbage, for SAVRs and mitral valve repairs, actually surgical mitral valve repairs, and most importantly, mitral clips that have now become very upcoming in the field of heart failure and in, structural cardiology, which could be helpful to your patients to reduce rehospitalizations.
I'd like to salute you and your team because not only are they going to be seeing patients inpatient, they actually are the team they're going to follow and see them on outpatient. So I think the planning for optimizing access to care and continued evaluation is great, and you have some questions.
I'd like to, first of all, that was excellent. One of the problems we all have in heart failure patients versus cancer patients is prognostication. Cancer patients, once you're on bullets, you kind of know you're on bullets. It's easy to prognosticate issue. We know it's very hard in heart failure, and that's why very few people get referred if there's not a palliative care program. One tool that I'd like to suggest that has been verified repetitively in the last few years is called the surprise question. And the surprise question is you ask yourself, would I be surprised if this patient died within the next 6 months? And if the answer is no, I would not be surprised, that correlates very high with the fact that that patient is likely going to die. So like when you said the patient who has 8 readmissions, you can say, you can ask yourself, would I be surprised if this person's dead in 6 months or a year, whatever time? If you say, I would not be surprised, it's time to have the end-of-life discussion.
That's a great point. The only thing that I'm going to tell you about that is, unfortunately, many of our residents are very surprised when some of these heart failure patients die. And I'm like, what do you mean that patient was very sick? No, the patient was not sick.
And that's where the importance got to be tailored by a cardiologist who can say, yeah, I don't want somebody who's a third-year medical student who's never seen somebody with heart failure making the surprise question analysis, but I believe that you could.
Yeah, definitely.
Terrence?
Thank you for that. I do worry that as evidence-based medicine continues in this area, we're going to end up with a diagram the size of this board to determine the treatment for patients with heart failure. But have you heard anything or heard of other hospitals using IV iron in anemic patients to reduce hospital admissions based on, like, I think Confirm, Effect, and the FAIR heart failure trials?
Sorry, my fault again. One more slide that I missed out was patients with IV iron therapy in patients who have iron deficiency, anemia, and heart failure has been shown to reduce both hospitalizations and mortality. One of the newest guideline updates in the most recent guidelines. So yes, think about IV iron therapy. And one of the things that we are trying to get is an infusion center as an outpatient to give IV iron therapy and IV diuretics as an outpatient to your patients as well.
Are they doing that at other hospitals? And
I'm not sure about here, but there are, like for example, who did I hear that from? I saw a patient recently in Alexandria that said that Cabrini, which is a private hospital in Alexandria, has an infusion center in the hospital that gives both iron as well as diuretics.
But several higher performing centers are doing that, and it's something that is being evaluated here. You might want to comment on this. Dr. Cavell took exception to they turned the lights off, by the way. So I'm sure it was meant in the right spirit of competition.
They're sicker patients, that's what I meant. Yes, sir.
You mentioned evaporating the drug, but you didn't tell us the mechanism. How does that drug work?
So that's a great question. So evaporatin is a HCN4 blocker. It blocks the funny currents, and so therefore keeps the heart rate down. So it is acts like a beta blocker, except it does not have the pleiotropic effects of beta blockade, because we know that beta blockers act not only by reducing the heart rate, but it also has effects on other things, lots of other things, right? But one of the advantages of evaporatin is it actually works only in the physiological resting membrane potentials of the SA nodal cells. So it's not going to make your patient too bradycardic when you actually put them on evaporatin. So that's one of the advantages. But the trials show that you have to add it to a beta blocker.
So we are at the end of our hour. Thank you very much. Wonderful presentation. We all learned something.